Hello and welcome to Head to Toe. Our first case is about collapse. We have a 77-year-old gentleman who presents to the emergency department. He has had a fall at home but can't remember what's happened. Before we learn more about what happened to him, let's go back to basics. We'll briefly cover how to take a history. First, we have a presenting complaint. Here, you can ask how he fell. What was he doing? What does he remember about that fall? How long does the episode last for? Next, the history of presenting complaint covers any previous falls, any triggers to him falling, and you might want to ask about any collateral history from family or witnesses that give rise to you understanding more about any associated factors accompanying his fall. In a past medical history, you want to explore what medical conditions he might have, in particular addressing any common and significant comorbidities, for example, heart problems, stroke, diabetes, or hypertension. In the same vein, you can also consider asking about a surgical history. In the medications or allergy section, you will want to cover any regular medications that the patient is on, medications for any conditions that he has, and then any drug allergies or allergies that precipitate any adverse reactions. For a family history, you will want to recap those significant medical conditions that you may have asked about in his past medical history, conditions that may lead to sudden death, or any known genetic conditions. Important information for a social history will cover the patient's mobility and whether he lives alone. You will also want to consider the usual questions about diet, level of activity, alcohol, smoking, and drugs. To complete your history, make sure you always ask about ideas, concerns, and expectations, and do your systems review. People can go about these in a multitude of ways, so find one that suits you. Let's go back to the patient now and have a think about what it all means for us. All of your questions can be considered in the format of symptoms integrated with the background history. We might have touched upon all of these factors from top to bottom. So let's go head to toe. Your head to toe differentials can be grouped into these categories: neurological, cardiovascular, metabolic and musculoskeletal. So let's start exploring. You may have come across the term syncope before, but what is syncope? Syncope is defined as a transient loss of consciousness and postural tone caused by diminished blood flow to the brain. In other words, brain ischemia. With this in mind, let's start going through our differentials, starting with the neurological. Neurological differentials can be split up between electrical problems, structural problems, and then the vascular supply to the brain. Electrical issues stem from inappropriate neuronal impulses, which in turn lead to a seizure, potentially causing syncope. These can be from a variety of different mechanisms, and examples of seizure disorders can be epilepsy or febrile seizures, and there are multiple other seizure disorders as well. Structural problems leading to raised intracranial pressure can be affected by an actual mass of a space-occupying lesion or in changes in cerebrospinal fluid regulation. This may be due to increased production of CSF, as we see in meningitis, obstruction of CSF flow, seen in types of hemorrhage, or increased venous pressure in certain chronic conditions like liver or heart failure. Lastly, the vascular supply to the brain may be compromised. The blood flow to the brain may have been limited, but can affect different functions due to the location of the ischemia. For example, the effects of a stroke versus a transient ischemic attack may be important. Next, let's consider the differential diagnoses arising from the vascular system. Vascular causes of syncope can be separated between reflex-mediated causes and orthostatic causes. Reflex-mediated causes are based upon a failure in the cardiovascular homeostasis, so the heart effectively doesn't pump blood effectively at all. Cardiovascular homeostasis relies on factors like temperature, pH, and blood pressure to auto-regulate, all factors that can be indicators of physiological shock. These, as well as psychological triggers, can be causes of a vagus vagal syncope or a situational syncope. Orthostatic causes, however, are due to poor vessel maintenance of adequate blood flow, leading to hypertension. As vasoconstriction and vasodilation are controlled by sympathetic and parasympathetic stimuli, we consider factors that affect the autonomic nervous system. In particular, comorbidities like diabetes or Parkinson's disease affect the transmission of neural signals, and certain drugs may induce hypotension, namely alpha-1 blockers or diuretics. Okay, next we have cardiac causes to cover. Cardiac function is determined by the structure of the heart to mechanically pump blood and the electrical control of the heart muscle. Therefore, we can discuss structural and arrhythmogenic causes of cardiac differentials for syncope. Structural causes can be considered into those that affect the preload, the contraction itself, and those that affect afterload. Preload is defined as the level of stretch present in the cardiac muscle prior to contraction. This can be understood as the end diastolic volume or pressure. A pulmonary embolism or hypertension may decrease the preload, affecting the force of contraction. Contractility relies on the integrity of the heart muscle, and a myocardial infarction, which leads to necrosis and scarring of that heart muscle, will impede effective contraction. Afterload is defined as the force against which the heart must contract against, in other words, the ventricular wall stress. An aortic valve stenosis or cardiac tamponade, which increases the pressure against which blood must flow, will increase that afterload, decreasing the stroke volume. Arrhythmogenic causes of syncope can be thought of in bradycardic and tachycardic causes. Where a heart rate is too slow, bradycardic, and is not optimized for adequate perfusion to meet the demands of the body, i.e. in types of heart block or sick sinus syndrome, syncope may occur. Where the heart rate is too fast and is a limiting factor in producing an effective stroke volume, i.e. in atrial fibrillation or ventricular tachycardia, syncope may occur in these instances also. Moving on to metabolic causes now. Firstly, the key components for metabolism can be thought of as glucose and oxygen, and for the brain, the blood in which it is delivered. Therefore, we will discuss these. Hypoglycemia. It is important to consider someone's eating patterns, if they have binged or fasted, whether someone has an endocrine disorder and therefore cannot regulate that glucose control, like diabetes, and what medication a patient is on, so external factors that will affect that control. In hypoxia, this can arise from a lack of oxygen, either in the environment or as a result of a lung condition which limits its uptake, or a lack of hemoglobin, as seen in anemia. With hypovolemia, where the fluid content decreases and dehydration follows a hypotension, it may be important to consider where and how that fluid may be lost. There are many situations, for example nausea and vomiting, severe hemorrhage or burns, or excessive use of diuretics, where fluid control is compromised. And finally, last but not least, let's talk about the musculoskeletal causes of syncope. There may not be a true musculoskeletal cause of syncope, but it is always important to consider a history of trauma precipitating any of the causes that we have discussed earlier in the video. So, in summary, we have covered a whole ton of differential causes of syncope. For neurological, we have talked about electrical, structural, and vascular issues. Within the vascular system, we discussed reflex-mediated and orthostatic causes of syncope. In the cardiac system, we covered structural and arrhythmogenic causes, diving into preload, contractility, afterload, bradycardia, and tachycardia. Metabolic causes touched upon hypoglycemia, hypoxia, and hypovolemia. And finally, it is always important to remember a musculoskeletal and trauma history for any patient who presents with syncope. Thank you so much for watching this video. I hope that it has raised some interesting learning points for you. Consider the anatomy and physiology, the pathology, the differential diagnoses that we've covered, and then think about your risk stratification and your management. Best of luck with your independent learning.